Coronary obstruction is a very rare complication that occurs during TAVR. Usually it occurs in less than 1% of patients undergoing TAVR. But when it happens, it's a very nasty complication with a mortality reach up to 50% of mortality. So it's rare, but it's important to recognize. And when we notice some anatomies which are prone to coronary obstruction, it's important to intervene and to understand how to manage, but also how to avoid and prevent coronary obstruction. This is a very important question. Sometimes it's very rare, but in some circumstances they are unpredictable, let's say, but in most of the cases we can understand which are the anatomies who are more prone to coronary obstruction. Essentially, the setting of valve in valve is always a little bit more challenging, and also TAVR in TAVR can be, cases in which operators should be aware of the potential risk of coronary obstruction, and in presence of a very shallow anatomy, small sinuses, small sinotubular junction, and the predicted distance between the new valve that we are going to implant and the presence of low coronary artery ostia can be a predictor of coronary obstruction. So when we see a lot of anatomical details which are not okay for us, it is better to plan a strategy to avoid coronary obstruction. So chimney stenting, I think, is a older approach. It's very simple to be performed. Essentially, it was performed before TAVR is derived from a technique which was utilized in the endovascular approach. It consists in parking two stents or the stent in the coronary that we deem at higher risk of coronary obstruction. And once we have deployed the transcatheter heart valve in position, we can pull back, retrieve the stent, and deploy it with a generous protrusion inside of the aorta, so that we create a sort of tunnel between the aorta and the coronary ostium. The problem of the chimney stenting is that people that receive chimney, for sure, they have to take the DAPT to avoid and to minimize the risk of stent thrombosis. The problem is that in case of future intervention, we have some troubles because placing another valve can carry the risk of stent crushing, deformation. And also in case of a coronary re-engagement, I think that it's a very challenging scenario, and with the presence of a protruding stent, sometimes we will be not able to re-engage the coronary ostium. So for all these reasons, in the recent years, some operators have developed and improved the BASILICA technique, which consists through the electrosurgery in a dual splitting of the leaflet just in the middle. So cutting the leaflet, we open up the leaflet and we create a better flow through the leaflets, across the leaflets towards the coronary ostium. I think this is a little bit more elegant technique. It's a little bit more challenging and technical challenging, let's say. But in the last years, also some devices has been developed to make this technique more standardized. According to the procedural outcome, when we place stent, so in the chimney group, we observed a higher rate of contrast which was utilized during the TAVR procedures. And this translates in a higher risk of acute kidney injury after the performance of this technique. Chimney stenting has also a higher risk of minor bleedings because patients are taking more frequently the DAPT after the procedure, and so they are more prone to bleeding compared to the other technique. In terms of safety, let's say that in the chimney group, we observed just one complete coronary obstruction. I mean, the operators were pulling back the stent and they had a loss of stent. So the coronary had an abrupt closure, and so the patient had to undergo an urgent bypass, and unfortunately he died some days after the procedure. A complete coronary obstruction was observed also in 3 cases in BASILICA group, In 2 cases was related to leaflet prolapse. In another case, there was some hematoma around the circ. And it was these 3 complications were managed putting a stent as bailout stenting strategy. There's another thing that should be underlined. In around 8-10% of the BASILICA procedures, finally the operators decide to put a bailout stent because they had some concerns about the technical success of the procedure, but the stents were placed even in absence of a clear coronary obstruction. I think it's always better to understand both the techniques because chimney is easy to be performed. Sometimes when we have a very unstable patient in an urgent setting, I think performing a chimney stenting is easier and less demanding compared to the BASILICA technique. But in the future, I think that the operator, especially in high center volume, should be able to perform easily the BASILICA. But in the near future, I also believe that some devices will be introduced in the clinical practice, like the shortcut with very promising data, so that the operators can perform the BASILICA technique in a very easy way and maybe cutting some complication that we observe with this technique at the present studies.